some series of interesting cases or complaints or significant events, because she's the main SCA person in charge. She can be here, but what we've done is we've created this very simple sort of thing. We'll do a simple presentation on QT interval. We'll follow it up with asthma, and if there's something interesting, some cases or something, we'll do that. And finally, we'll get Ashish his time to go with us and deliver. And if there are any questions for Ashish, Ashish is a GI physician at the ARI, so he should be able to. Should be.
Sure.
I think Ashish, you'll just about manage. I think you'll just about manage. But before that, I just wondered. We all know each other, but I don't think a lot of us know Mary. Mary, do you want to introduce yourself? We'll do a whole round of introductions actually.
My name is Mary Jennifer, but please call me Mary. I qualified ICCT, that was about nearly a year and a half ago. Yes, I'm local in Old Meldrum Medical Practice and I live in Inverary. I'm a mom of 3. Is there any other thing you want to know about me?
You okay? You well watered and
Yeah, and I love the drink.
perfect. Mary, do you know everyone here? Do you want people to go around and introduce themselves very briefly?
Yeah, I know Michelle. I know Amar. I know Charlotte. I know Carol.
Perfect. You know everyone?
Yeah.
You know Ashish? You know Caroline?
I see his letters.
Oh,
Ah,
very short.
That's good.
you know Caroline, you know
Yeah,
Helen. Do you know the table there?
No.
So can we just have a very brief introduction just for
I'm
Mary's benefit?
Emily, one of the practice nurses.
Nice to meet you.
I'm Kirstine, one of the MPs.
Nice to meet you.
I'm Solma, one of the MPs.
Nice to meet you.
And I'm Helen, we
Yeah.
just chatted.
Yeah.
Nice,
We met
you know.
somewhere. Yeah.
So we've got 3 more to come. Claire and Ange will come in just because it's the first one, and they would want to be there as well. Claire's our complaints person, so that's the way.
That's a terrible way to introduce her because she's paranoid because every time she walks into the room people say, who's complaining? Who's complaining?
Poor thing. I don't know how she manages it. I don't know how she manages it.
Claire just seems to be the one that comes to tell you.
So if folk are happy, we'll just kickstart and please bear with me. We are not techies like Amir, so we'll try and do our best. I've already made a mess of it. Bear with me. Amir, how do you start the presentation on?
See the little,
There's
Usually
one.
bottom
see the
right.
bottom
Bottom right.
Ah,
the
okay.
little presenter thing. Yeah, that's it.
It's fine, Raj,
That's it.
because if you're not perfect, then everybody else is going to.
I'm setting the scene, so
Yeah.
nobody's scared after me. I would want people to drink enough mimosa to forget all the bad bits and just focus on the best bits, So let me just then start from start, man. Oh. Okay. I'll just have to do it manually. Sorry. So this is QT interval. I don't think I would exaggerate if I say that QT paradigm is very similar to what we used to do with drugs and allergies. We always used to check, are you allergic to penicillin? I think QT is kind of getting that profile now because there are so many combinations of drugs we use, and QT is that hidden thing where people can come to a lot of harm if we are not careful with the choice of our scripts and combinations. So this one, I think one of the reasons we got this was we were getting a lot of feedback from different parts of our system saying, oh, this patient was prescribed this is not safe, we need to kind of not prescribe this combination again. And that's why we want to do something about QT interval. So I'll keep it very low level, but it will be slightly dry, so keep helping yourself to mimosa. Okay? So it's a nice picture of a heart, and I've put a nice picture of a ECG. I won't go into that. I won't go into the details. QT interval, essentially in layman's term, the heart will, depolarize and then repolarize, where it kind of refreshes and sort of restart its engine, and the whole cycle is QT interval. So QT interval denotes the whole cycle of one activity cycle of the heart. And I've just put 500. I don't want you to kind of worry about it, but just keep that in mind because I'll come back to that later. Again, I won't go into the bits of heart physiology or ECGs because that's not the whole idea today. I think it's more to understand about why we need to be more careful about QT interval. So, like I said, QT interval represents the duration of activation and recovery of the ventricular muscle. So if you think about it, it's like doing a cycle of washing your clothes in a washing machine from start to finish to the time it rinses its blood out. That's what QT interval represents. And each beat must fire and then reset. So QT interval will show us how long the full cycle takes. If the heart is beating faster, the QT interval gets adjusted because the beat is happening a bit quicker. So the QT interval becomes a bit shorter. If the heart is bradycardic, very slow for whatever reason, the QT interval automatically resets and becomes a little bit longer. The whole beats, it's just because it's got more time to do things, right? Because the heart is going slowly. But why does it matter? It's the problem happens when QT interval does not really adapt to the speed of the heart, and that will happen if it's a diseased heart, if they've got some sort of underlying QT interval pathology, or more pertinent to our sort of presentation, if we have started them on a combination of drugs which are delaying the QT interval so it does not really get to adapt to the heart rate. So if the heart rate goes high and the QT interval does not set itself, then things don't go as well as they should. And this is what happens. So again, we don't need to mug up or get too worried about the names here, but Torsades de Pointes is the main sort of arrhythmia which happens when QT interval is not able to adapt to the heart rate, or if we have buggered it with our medication cocktails. Paradoxically, it's not just the fast heart rate where QT interval can be an issue. Bradycardia and heart blocks also make it much more easy for the heart to go into torsades with QT interval drugs. So it's not just tachycardia we're talking about. So this is the normal ECG. I'm sure everyone's seen these ECGs when we do the ECGs. That is Torsades de Pointes, which basically is a polymorphic ventricular tachycardia. And if you go back to the high school physics, it looks like a wave, builds up, goes down, builds up, goes down. And this is why it is very important, because torsade can degenerate into ventricular fibrillation, which we all know is equal to death. So often dose related and unmasked by other things as well, but I'll go into that in a minute. Some fun facts. I thought, why not dig into it a little bit deeper and try and understand what happens when torsade happens. And within 10 seconds of a torsade, people are expected to have a syncopal spell. If it does not settle down in a minute or two, they're going to die. They go into ventricular fibrillation. Unless, of course, we've got a cardiac defibrillator and we kind of do a sort of, buzzing of the heart. So that's where torsade is very important and very dangerous. The lucky ones, there are some lucky ones. Some episodes of torsade may just last very few seconds or milliseconds. And in those cases, arrhythmia may not lead to all the things we are worried about, like death and significant syncope and harm to the patient. But they will get these symptoms, and isn't it funny, we come across these symptoms with so many patients who call us and we look at their medications and say, no, you're fine, because generally most people tend to be fine, but lightheadedness, dizziness, palpitations, transient shortness of breath, which again, such a vague and wonderful symptom, and seizuring is another thing. So if they take a syncopal spell with Torsad, they are probably going to take a seizure as well at the end, and that is just with the arrhythmia causing hypoxia. Brain does not go to the blood does not go to the brain, and they basically get tonic-clonic seizure activity because of that. So, not so fun facts, I guess. But there are certain things where we have to be even more careful when we are giving these drugs, which may induce QT prolongation. And bradycardia, heart block, I've already touched on that. There are some people with congenital long QT syndrome will not go into that. They just have that. It's the way the heart wiring is done. There's nothing they can do about it, or us. Structural heart diseases or heart failure. A diseased heart is ripe to get more sensitive to QT interval prolongation. Renal or hepatic impairment. So if there are some drugs which are cleared by the liver, some drugs which are cleared by the kidneys. If there's delayed clearance and accumulation of drug at toxic doses, especially the ones we're talking about, that is going to give you a Torsad. Not very relevant for this room, I guess, but female sex seems to be more prone to getting QT prolongation. So, Amir, we two are okay.
What's the incidence, Raj? Like, how often does it happen in reality?
That's homework.
Is it?
That's homework, yeah. I've got some slides on that, but that's homework. I think I want people to actually get curious about QT interval. I've not even given the normal QT interval because I thought, someone is definitely going to ask me, what's the normal QT interval? I was like, that's homework. Because I gave 500, the figure of 500 milliseconds. That's what we need to remember, because that's when all the problems start. If we get a ECG and if it's over 500, they are in trouble, right? And I'll go into that a little bit more.
How accurate is the, should we be relying on ECG?
Yes, so
As in,
most
you
of
measure
the
it yourself or?
no. I think most ECGs. So QT interval in a ECG is given as two. If you look at it carefully, it'll be QT and then corrected QT. Corrected QT is for the normal heart rate, right? Because like I said, QT adapts to the heart rate. So the ECGs are very sensitive. The reporting is very sensitive, and I think we can very happily rely on these figures. So corrected QT is what we are looking at. We're not looking at the uncorrected one. So QTC on the ECG lead is what we are going to look at. So again, this is just a plagiarized slide from a different slide presentation, which just shows how a normal heart rhythm going, and then suddenly a drug-induced Torsad happens, and then it can of course evolve into a ventricular fibrillation and lead to death. A little bit more about drugs, because I think our presentation is not to explain everything about QT interval, but more for primary care clinicians, and I suppose secondary care as well, where how do we apply the logic of QT interval and prescribing, because that's what's more practically applied in our practices. And there are three sort of areas that we have to actually focus on. So one is a pharmacodynamic interaction where combination of drugs act together and increase QT interval, maybe because both of them have that effect and they have a synergistic effect and add to each other and cause all sorts of problems we've talked about. And one big example of that is citalopram and macrolide antibiotics. A very common combination, I presume 5 years now for back, when QT interval was not as well known. I wouldn't be surprised that there were a lot of people getting clarithromycin and citalopram together. I think they still do in a lot of areas, and most of us would have not thought too much about it, but that combination itself is quite dangerous because citalopram and macrolide both have effect on QT interval prolongation with different sort of mechanisms. I'll go into that again. So one is combination, the other is pharmacokinetic interaction. So they may not be drugs which actually increase the QT interval directly, but they could actually be drugs which inhibit certain enzymes in the body, which would then increase the QT interval prolonging drug levels. So one of them is fluconazole, again something we prescribe very commonly for people with thrush. I never thought too much about QT interval prolongation for thrush prescriptions in my 22 years as a GP till lately, and fluconazole needs to be carefully given when we are doing a look at this patients with complex prescribing issues, especially people with SMS issues, for example. And maybe I'll get Carol to tell a little bit later about SMS patients and the combinations that she's already tackled before, because antipsychotics and methadone both have that synergistic effect on QT prolongation. Third thing we have to look at in terms of these drugs is there's the underlying sort of electrolyte imbalances. So if they're hypokalemic, low potassium, low magnesium, low calcium, they all have higher sensitivity to get this QT prolongation. So again, I've not put things here for you guys to kind of get worried about or start panicking about. It's more as a conversation starter, because we do these things every day, and we can start looking at every drug in detail and check against every interaction. But very simple things, we give furosemide to so many patients and indapamides and everything, and we see a lot of hypokalemic blood test results coming back. So just a conversation starter. So maybe next time when you've got someone with hypokalemic results, maybe look at the other medications, because someone who's fit and healthy just on indapamide for hypertension is probably going to be okay with a mild to moderate hypokalemia, but someone with antipsychotics like quetiapine or on methadone, etc., they may actually be more at risk with diuretics giving them hypokalemia. So just something to bear in mind. This is just a table again. I lifted off one of the links which I've inserted somewhere. I thought it was a good table, and I'll give the context for the table again. We don't need to remember each drug. We can't. There are so many drugs which cause QT interval prolongation. But I'll just give you a hint. This whole presentation is being designed or has been designed using citalopram and escitalopram as the case study, for example. Okay? Because it's impossible to cover every single drug for this particular issue. So SSRIs, citalopram, escitalopram, MHRA has given a warning on these. They give you dose-dependent QT interval prolongation. I actually have the data of how much dose leads to how much prolongation, but I've not inserted in the slide and I can't remember for the life of me. Citalopram is worse than escitalopram. Escitalopram is half as potent in terms of QT interval, but they are both classed as drugs to be avoided when combinations are prescribed. Escitalopram is a fantastic drug for generalized anxiety disorder. Citalopram works very well for anxiety and mood. And the question is, how good are they with other drugs? And that will get sort of more obvious as we go on. Amitriptyline, tricyclic antidepressants, they've got additive effects with antipsychotics, SSRIs, and make things worse. Macrolides, as I've already covered. So certainly there's advisories of not using clarithromycin or erythromycin for people who are on high-dose methadone, for example, or on complex antipsychotics like high-dose quetiapine or high-dose sulpirides and high-dose haloperidol, chlorpromazines, because they are going to come to harm. Antipsychotics, again, like I said, they cause the same effect. Methadone is a dose-dependent sort of effect, and over 100 milligram per day are the ones who are at highest risk. Antiemetics, again, things which we prescribe so commonly, ondansetron, domperidone. Domperidone, I know MHRA advisory came a few years ago, so very few people get domperidone now. But ondansetron is getting more and more popular with a lot of patients coming from the hospital, and we do prescribe them. So this is just I've put in a link and I'll share the presentation about, yes, this is an issue. How do we actually risk manage QT interval and drug prescribing? So this is just like a breakdown of, if you're going to prescribe something, be aware if it actually impacts the QT interval, especially things like clarithromycin, macrolide antibiotics, fluoroquinolones like ciprofloxacins, citalopram, the usual ones, the fluconazole, all those drugs. Consider the risk and benefits of using this medication causing a long QT interval. So a simple case would be someone with depression. Would it be better to give sertraline over citalopram? And again, conversation starter, think about it. Review the intended duration, dose, and frequency of the medicine. So I actually went a bit deeper into fluconazole because that really worried me, because I prescribe fluconazole as a CN lead without speaking to patients or looking at the history. So what do? One-off dose, 150 milligram, is unlikely to cause any QT interval related issue, even with other potent combinations. So we shouldn't worry about single snap short courses. It's when people are going to get those weekly courses of fluconazole or a longer course for 7 to 14 days, that's when we need to think a little bit more about it. Avoid 2 or more medicines which can cause a long QT interval, especially if the person has unmodifiable risk factors. Unmodifiable risk factors are long QT interval, congenital, or certain other diseased hearts like heart failure. We can't really modify someone with a heart failure. They've got heart failure, they've got heart failure. Carry out ECG if recommended by the manufacturer. And I pretty much laughed at it because 10 years ago there was a huge debate in our previous practice I used to work where senior GPs refused to do ECGs because psychiatry had suddenly started asking primary care to do ECGs for high dose antipsychotics and citalopram. And the GP said, we've never done it, it's not our work, and people have been fine for 20 years, I've been working, so why should we do it? And I think things are moving. We don't often do ECGs, but there are a lot of drugs where the manufacturer will recommend ECGs. Certainly high dose citalopram is one of them. Consider repeating ECGs. I know some people do. A lot of us don't. I've never done repeat ECGs for these issues because we'll never stop doing ECGs if we start only focusing on this area and start doing ECGs. But again, something to be aware of, especially if you've seen someone with an abnormal ECG and you're doing a changeover based on that ECG. Just because it's a very dry presentation, I thought I'd just put some scenarios, again, more for starting a conversation. A lot of patients come to us with IBS or cyclical vomiting, and a lot of patients get domperidone, and some of them are on citalopram. And we've got old Aberdeen practice where half the population have got anxiety and they're on SSRIs, and then they come with nausea because nausea is very common in these populations, and these combinations are not unheard of, but this is someone which is actually a case series where someone given this combination ended up with QT interval prolongation and side effects based on that. And I think the way to cop out is start thinking about things like cyclizine, which is a much more safer antiemetic compared to domperidone and ondansetron, for example. So try cyclizine. What do we do when we get these ECGs? So again, I've already said, remember 500, because that's the sort of one which should really alert us. If someone is on a combination, they've come with, or not even a strong combination, but they're coming with these palpitations and dizzy spells, and you've done an ECG and the QT corrected interval is more than 500, there is a problem, it needs to be looked at. So look at it, whether it's a drug, whether it's something more underlying, they need to be followed up carefully.
And just
of course,
the ECGs. See if you've got the mobile ones, the Cardias, and does that capture?
they don't give you.
They don't give you 2C.
Cardias, I don't think give you all these things.
They won't give you QTC
I
probably.
I think Cardia in the app sometimes gives you all the details, but I'm not too sure if they give you QT interval. And again, I mean, I don't know. I just want to check, does everyone here look at QTC for every ECG they look at? I don't. Is that something?
Does it not normally tell you?
It tells you, but you actually look at it.
All ECG machines
I
give
always
all
look
the.
at it.
Yeah, but you always look at it.
I always
I
I
know,
do look
but
at it.
I'm
Yeah.
making guesstimations.
Yeah.
I always look at it if that's what I'm doing.
Looks a bit long.
So no, but you know
Maybe not always.
but you know when you're on duty in a hub and
Yeah.
they bring in say, is this
Don't get me
ECG
ruler,
okay?
I know.
And you're in between two complex cases. You look at the ECG, yeah, it looks okay. The leads are okay. Why was it done? It was a cardiac pain. I was like, I
It would come up in the text.
oh no, everything is there. QTC is there. It's all there on the ECG. But the reason I put it there is maybe just have a quick flick at the QTC as well to see what the QTC is.
For men and women.
So again, correct. So
One's 350 and one's 450. I just can't remember.
it's 450 and 470. So it's 450, 470, 500. These are the three numbers to
350 and
remember.
450 is what I was always taught.
Homework. So
It's changed. Since then.
450 to 500 milliseconds is when there could be a problem. Over 500, there definitely is a problem. Under 450, we can ignore it.
No, but I'm sure it was 350 for one of the genders.
Yeah,
I bet I know it is.
Could it be pre-corrected? Could that be the uncorrected one?
it could be the uncorrected one, I guess, because this is the corrected one. So if it's under 450, we can just rest easy. And if it's over 500, we should sweat out a little bit. This is a very good. Again, I don't know what the definition of good is, but it's a US-based app, and it covers all the QT medications. You can actually just download it, or just go on the computer and pop the name of the tablet you're about to prescribe. I'm not talking about every single tablet we do, but you know, when we are given a drug to be prescribed by a psychiatrist who wants to give a little bit of quetiapine on top of the haloperidol that they started, or something crazy like I've got mirtazapine already for him, and this, and I want you to give some amitriptyline as well. Or the neurologist tells us to prescribe amitriptyline for migraine for this patient on quetiapine, already on methadone, This is a good thing. Again, I'll circulate this website, and it's a clickable link, so you can just go through that. So it's a good one. I tested it out. It does give you a lot of information, and it's free to use. So if you register on it, it'll give you a free thing. So, like I said, I think the whole QT thing came about by multiple sort of discussions on patients who've been prescribed citalopram especially, and concerns by certain clinicians that they were then given something which could have caused harm, and most times it was a clarithromycin, and very easy to do it, especially if you're on call, you don't see all the meds, easy to do it. So I just thought I'd use citalopram as a case study with a complete ulterior motive here, which will come at the very end. So I started looking into citalopram and drugs which we commonly use. So they say avoid citalopram. If someone is on citalopram, avoid giving them any macrolide. Levofloxacin is azithromycin is slightly safer, but not completely so. Erythro and Clarithro definitely, they come up with a warning. So no cop-outs if we give them and they have a QT interval thing, because it's already flagged up by MHRA. Macrolides, they actually have a dual action, so they not just prolong the QT interval, they also inhibit the CYP3A4 enzyme, which will then increase the dose of citalopram circulating in the body, which will make citalopram more toxic, so ultimately will cause a high potential to cause an event. So that's citalopram and macrolides.
But can I ask,
Of
if
course.
the patient is allergic to every single other antibiotic and they are on citalopram, would you tell them to hold off to citalopram for a few days?
I suppose that's where the magic happens. I think that's where there's a grey area, because we are not ever told never to prescribe drugs. Even the QT interval thing, they basically say avoid these combinations. Avoid these combinations. There's certain ones they say should not be prescribed, but most times I think it's a case by case. I suppose if someone has risk of sepsis or something which they really need macrolides for, then again, if it's a 5-day course, as long as we have a full discussion with them, I suppose even if they hold off citalopram, they will still have some leftover circulating in the body. So I don't know the answer, but I suppose that's where case by case will come in, and I certainly tried looking for that, and the answers coming in Chat GPT were try using doxycycline. It's like, oh, they're allergic to tetracycline. Try using this. Right? So yeah, I've been through that. So citalopram and tricyclic antidepressants. Now we do use TCAs. So I do use TCAs with mirtazapine. I do use TCAs with sertralines, and I think these cocktails are allowed, and a lot of people get them. But this one is definitely blacklisted. Citalopram and TCAs just don't go hand in hand, and escitalopram is in the same category, by the way. So amitriptyline, nortriptyline, imipramine, clomipramine, Vyavoid, same thing. Combination synergistic effect, both will cause QT interval prolongation and high risk of arrhythmias. Citalopram and fluoroquinolone. So I think if you're on citalopram, your range of medications you can use suddenly starts getting very narrowed down, because you can't use levofloxacin is not as bad as others, and moxifloxacin, which we don't use generally. I don't know if you use that in the hospital. No, I suppose it's in other countries. So we don't often use, and in fact I think we are not very heavy users of fluoroquinolones anyways nowadays, with all the C. diff and all that. But still, there are a lot of people who do need them, and if they are on citalopram, they should not be getting them. Again, it says avoid. Same thing, QT prolongation, synergistic effect. Avoid citalopram with these antiemetics. So if they're on a citalopram, don't give them ondansetron, don't give them domperidone, don't give them Stemetil. And it's again MHRA ratified, so no cop-outs if you give them and they end up with an event. Ondansetron is particularly unsafe as well. Well recognized QT signal, but again, IV ondansetrons is not something we do very often. Hydroxyzine, it's one of the best drugs I use for people with itch. In my previous life as a GP, till hydroxyzine got blacklisted as well. We often used to give hydroxyzine to people who were not sleeping, where we didn't want to give them Zopiclones. I still will give them hydroxyzine at times. Very good for itching. It's an older sort of drug, so sedative side effect and anti-itch side effect is really good. So it does work very well, but if they're on citalopram, they shouldn't be getting it. And it's blacklisted by MHRA and other sort of European sort of bodies as well. And significantly increases Torsad incidence in vulnerable patients. If they are on citalopram, they can get, or they should not technically get, longer courses of these drugs. Azole drugs are inhibitors of enzymes, so again the same thing, they will lead to prolongation. So we keep going on and on with citalopram. They should not be co-prescribed with all these class of drugs. And this is the list of drugs which we need to avoid with citalopram. Amiodarone is one of them, so if they've got AF, if they need sotalol or amiodarone, they can get it.
There's quite a lot of people on citalopram plus low dose amitriptyline
And methadone.
There's a lot
Correct.
of people on
Correct.
these medications.
Correct.
So it's red, it's flagged red.
It's blacklisted. These combinations are actually blacklisted, methadone and these things.
Audit to do, so I suppose, is it?
So that's one of the, so we thought QT interval thing should not be just a one-off presentation. It should be a regular presentation with different sort of caveats or case
I
studies,
think that
and to trigger and
Yeah.
sort of find out audits that we may need to
probably,
do.
like you said, the key thing would be the discussion you're having, saying that maybe there is very limited other options, but actually it's a risk, and are you happy with this risk? If you're
Yeah.
not happy with it, that kind of chat, isn't it?
Yeah.
If you're
Yeah.
starting or thinking of switching people over, some people will be happy with it, I suppose, and some
Yeah.
people may not be. But there may be very limited other options.
Yeah.
We have a problem with domperidone. Because previously, people used to. I mean, that's
Everyone used to be on domperidone
Yeah.
for months.
Domperidone
That
for
was like,
years,
oh,
that's
that's
the only-
wise, very
So
cool.
so lots of people with gastroparesis and ongoing gastric emptying problems. Maybe you had to have this conversation because that was the only drug which worked with them.
Yeah. So
then-
how do you risk manage that
So
now?
we tell them exactly that there is this theoretical risk. Are you happy to go ahead and try to document that?
Yeah.
But I mean, I'm not seeing this combination, but that per se.
Yeah.
is
I think in
that-
primary care, the problem is these patients are already on multiple medications,
Yes.
and then the risk actually gets amplified, and that's the issue. And I think there were some mitigation strategies which I thought were quite good, and I used one of them. I used cyclizine for someone who called, and it was the same thing. See and lead message from patient: can I get this drug which I was asked, which I was told would be given to me, and with this thing I said no, I'll give you something else. Try cyclizine and see how it goes. And yeah, so I think there are some mitigations. Doxycycline suddenly becomes a star player for penicillin allergic patients. I think it already is. I think we use a lot of doxy now. So yeah.
Why would you not use metoclopramide instead of domperidone? Why would you use cyclizine? A different mechanism of action.
It's not the extra pyramidal thing with
Yeah, there's-
chloride a lot.
There is something else.
And then you have the extrapyramidal system.
Yeah.
Drug-induced Parkinson's,
But-
Yes.
There were
Parkinsonism.
other problems.
If the reason you're using domperidone is because of a gastric
Gastroparesis,
it
yeah.
should be it should be a prokinetic
Yeah.
antiemetic,
Yeah.
not cyclizine, which
Yeah.
is more of a centrally
Correct,
acting.
correct, correct.
And it doesn't work. So because it's not plus the added problem is, I mean, there is an addictive element to cyclizine as well.
Yeah.
And that's a big problem. So
Is
once
it?
you
Really?
So we've had to admit one day.
Really? I don't know.
And you know, it was a challenge. We had to take that off.
Cyclizine.
Yeah.
I didn't know about cyclizine at all.
Cyclizine potentiates the next well. People take packets of
She
it.
just was on
Oh,
that,
really?
and she
Yeah.
didn't need it, but she couldn't live without it.
Wow.
And she went into IV cyclizine, and it was just one thing after another. So we had to literally admit her to stop that drug. So you know,
And that's
that's
where.
an extreme. I mean, that's
And what about metoclopramide? Do you use that? Because we used to use a lot of metoclopramide, and then we had those.
so we have these EHA directives for both of these drugs.
Yeah.
So we can't use them for more than a month. So we are using them, but with the caveat that you give it for a month, and hopefully we tide them over. But you can't give it for longer than that.
I think it is a problem because you do
hand
have
from
these patients that have this recurrent cyclical vomiting, don't you? You're completely stuck. I mean, I find myself sometimes completely stuck about what to use because it seems to have been through everything.
There used to be, I mean, I don't know if you're old enough to remember Cisapride.
I'm very old. Yes, I do remember Cisapride.
Yes,
That
I
drug
do.
went-
I remember.
I mean, that
too.
drug had hit the market, and it was a big, I mean, I think it was $1 billion.
It was a magic drug at
It was
that
a
time.
magic drug, and this happened. So it's off. That company
Cisapride
got
is totally
busted.
gone.
It's
Yeah.
gone.
Totally
So a
gone.
drug and a company went bust because of QT. So it is.
Yeah.
Is there any way to stabilize QT? Like if you're taking, you mentioned magnesium. Is there any
Reducing doses. Reducing dose of medication is one strategy.
dependent?
Or so it's dose dependent. A lot of these are dose dependent. So either reduce the dose, stop the dose, or alternatives. These are the only three strategies.
I think
Don't
that
start
magnesium.
Don't initiate stall
Sorry.
Don't start
Yeah, don't-
So do you know when I said my presentation has an ulterior motive, I'm coming slowly to that. Because that's exactly what I thought when I was doing the presentation. I was like, why should we even give citalopram to anyone?
Because I think it works, that's all right. But the magnesium thing's interesting as well because we've got so many people on long-term PPIs and we're not
Yeah.
we're doing UMEs all the time, but
Yeah.
you have to go into different page to check the magnesium.
And once you start,
so you don't always do it. You don't know what the magnesium
and I think it's almost like a stick on the back. Once you start doing magnesiums and find sort of subtle low magnesiums, they're on that magnasparte, and then we check it, and then magnasparte, and same with Sandoke. You know, you get into these things, very difficult to get these patients off your back. They almost turn into ghosts, I think. So anyways, I think, like I said, this presentation is not meant to scare us, although I was a bit scared of citalopram by the end of it. But it's interesting. I think it just shows how deeply it creeps into our day-to-day prescribing. It's not just citalopram, it's antiemetics, it's people on SMS, and me and Carol have a we had a chat on that
Yeah.
because I think you had done an audit
Well,
on
we
methadone.
did,
And
yeah, a number of years ago when I worked at the homeless practice with Richard Legg, we
while we're talking about SMS,
we
can I
took
talk about it?
everybody
No, thank
off
you.
Alcohol.
methadone.
Alcoholic, this is
Everybody was on
alcohol. I'll have the
methadone. We took
alcohol.
them all
Oh,
off
sorry.
citalopram and amitriptyline, and that was a
Yeah. Alcohol.
no, not the alcohol. No,
Oh.
I'm in the alcohol free.
Alcohol.
But yeah, we took everybody. We just basically told them, you're not getting your citalopram anymore. We'll give you something else, you know. And so we took them off that. We took them off amitriptyline as well. We said too many people dying on amitriptyline. Let's just stop it.
Yeah.
That's it. Not much of a conversation.
Oh, good. And they just took it.
They didn't really have much of a choice, you know.
Yeah.
Richard was very good at that. I just followed on, you know.
So did you stop all amitriptylines?
We took everybody who was on methadone off citalopram and amitriptyline, and we always checked if anybody was going to go up to 100 milligrams of methadone. We always did an
ECGs.
ECG, but it was a bit. We're never really very sure because some would go to cardiology and they would say, "Oh, we don't really know what you should do," because you could say reduce the dose of methadone, but then people are using other drugs on top, and then you think, well, is that actually any safer? So we just would say to them, look, you know, your heart might stop. Because, you know, and they would say, it's okay as long as you give me the
Really not clear.
so something's going to kill me anyway, doctor, so just carry on. So, you know,
That's funny, isn't it? But it is quite challenging because I was seeing lead again. This QT has been hovering on my head, and normally we do SMS prescribing. They come on the phone. We ask them these box standard questions: new physical health issues, new mental health issues, any new medication, and we prescribe it. And I saw this patient was on methadone and amitriptyline, so I thought I'll be brave and I was like, so you know, I just want to have a wee chat because normally I would have given you, but amitriptyline, new research is showing that it's not the safest. Like, don't care. I was like, your heart can stop. Don't care, doc. It works for me. I was like, okay. I'll just document it. You know, what can you do? So I was like, okay. Well,
well, I think that's the thing. Document it. You advise them. That, I mean, when Richard and I decided to do it, we just decided that we were going to do it. We're just going to tell them
yeah.
we're stopping it. You know, so we're both stopping it. So there's no point coming to the other or coming to a locum. You know, we're stopping it because it's not safe, and we don't want you to die with this. And people just accepted it.
Accepted it.
Probably went and bought some from their friend.
I
but,
suppose
you know,
that-
we weren't prescribing it.
Yeah, so I think that's one area that we really need to look into, because you wonder of all these sudden deaths that happen in patients on SMS, how many of them are because of the cocktail of meds that they take?
Well, it will be because of the cocktail of meds. A lot of them are because of the cocktail.
Because they all
of
get sudden
medication.
deaths, don't they? They just
They
die.
do. They just die, and you know, we're prescribing stuff, then they're probably taking other stuff.
Off-street
they
drugs.
probably don't really know what it is that they're taking, but something will be combining
Yeah.
and causing something like that to happen.
And you know, those things can cause electrolyte imbalances as well.
Yeah.
You don't often check.
Yeah.
So you never know which is the
They
trigger.
won't come for tests though. You know, if you tell them your blood test, I think, I'll come. But they never do.
Raj, what about somebody who's on citalopram? You're just giving one of IM Stemetil?
That's alright. Well, like I said, one-off doses will not cause a problem. It's the heavier doses for longer. So it's all dose dependent and duration dependent as well. So
Yeah, sometimes you don't realize you're doing it. I mean, for instance, we get called up after this H. pylori
combination.
combination thing. You are giving Clarithrol to these people,
Yeah.
but you're not aware. You know,
Yeah.
you're focused
You
on
just do it as a
you
combined
combined
thing,
thing. You just will give first line treatment.
yeah.
But then you don't realize that there is this in the background.
Interaction.
That flags up. But I mean, with the electronic prescribing, it has improved in the hospital because you can't give it. It will flag up.
This is a very interesting
Yeah,
one
so-
because we've got two different things. We've got EMIS in one part of the system and Vision. Vision is really good. Vision flags these things up. That's where all the flags have been coming to us. EMIS is very difficult to look at these things. EMIS will not stop you. Vision literally stops you from prescribing.
I'm with Raj on that.
Vision does.
Vision is
It
really
does
It
tell
tells
you.
you, everything's got
It tells
QT
you.
from pre-1.
Exactly.
Yeah,
You
Tells
check
you,
anything.
Yeah.
I like Vision. Anyways, we'll move to the next slide. So That's my question really. Should we really prescribe citalopram or escitalopram? And again, we can't stop giving it to everyone. But I suppose we need to just think harder next time we are about to give citalopram. And that's what I think. I stopped, in fact, I've stopped giving citalopram some time ago. I still kept giving escitalopram up to 20 milligram because I always thought
Escitalopram on the formulary?
it is generally accepted, but it's
I
again.
know, is it on our formulary though? I know it's accepted. Accepted by whom?
I think it's historical. We've always given escitalopram years, decades now. It's old.
I think it's on formula. I don't
It
know,
should be,
I
it should
couldn't
be.
say for sure.
But the risks that apply to citalopram apply to escitalopram as well. Less so, but they do. So risk management and governance standpoint, I think this is important. Is everyone treating citalopram as a last resort, or second line, or third line, or whatever, or are there people who still like citalopram? Because it's all historical. I know some GPs in my own practice, they used to swear by citalopram, escitalopram. And it's about our practices. I suppose we need to look at that, and not because it's ineffective, but because QT liability is dose dependent and well documented. Interaction profile is I should have written very broad, not broad, and it's when I said in one of the slides we don't need to remember all these because I think it's totally impractical for us to actually operationally check every single patient for every single interaction if they're on certain medications like citalopram. So this is actually these are not my caveats, these are already there in sort of literature. Primary care prescribing now expects safer first line options, and citalopram and escitalopram are not in that. So sertraline and fluoxetine are the two which are the first line recommended things, and it's all MHRA guidance which has led to this hierarchy. So that's covered already. So this is something simple. Fluconazole is a moderate inhibitor. Clinical significant QT effect generally requires higher plasma levels sustained for multiple days. So we do not need to worry about single snapshot scripts. They should be alright. And that was my ulterior motive in the thing. Do we need to start moving away from citalopram and escitalopram altogether?
Yes.
I don't know.
Yeah, it's obvious like the problem.
Yeah.
With every medication.
And there's other medications that
I don't think you even think if
And you'll
somebody's
be-
not responding to sertraline and fluoxetine, is citalopram really going to be that different?
Yeah, that's true.
What you do wonder is another necessary. If you tried two already, is the
Why not move to the next
Point, yeah.
mirtazapines of the world, which are much
then
safer?
vaccine or
Oh, but-
something.
So venlafaxine has QT interval effect as well.
Okay.
That's why they
But-
made us stop it.
But it's so venlafaxine. I think you've got to do ECGs, don't you?
You have to do ECGs.
ECGs for higher dose venlafaxine. Over 150, I think. Or is it over 225? I think, is it?
Anyways, another one is not worth prescribing because it's too much hassle.
Yeah.
That's true. I do like my venlafaxine scripts. I because they work. They do work.
Well, that's why I use citalopram because I feel it works better than sertraline.
So we're delighted to know QT interval presentation is now finished. You don't need to- Thanks very much for listening.